Okay, so good morning. We're doing bacterial diseases today. Welcome to those joining us remotely. We are back up and running with Panopto. So I think we still have room at the scope.
Yeah, I don't know if we're here.
So do you want a different?
Someone here.
Resume here. So I heard Manuel say erythrasma. You certainly have a compact horn, and then you're going to look in that horn for organisms. So if your horn is abnormal, you want to look and see what's there. Oops. So erythrasma, you typically find amphiphilic rods, and usually vertically oriented. They're not jumping out in big number in this example, but you got a little bit there. So let's see if we can get our pointer going here. So you can see them right in there and right here. Actually, still online, we're not seeing them at all. The 50%. Let's see if we've got amphiphilic organisms there in the cornea. Okay, very good. Let's move right along. And then, clinically, what's Lambert first? So most of them we don't end up with a biopsy. Here's another example just to show you the horn can be compact hyperkeratotic or more basket weave. This one has a lot more visible organisms. So if you look up in here, you see plenty there. Okay. So erythrasma done. Let's do so Shufeng, where do you think you are on the body?
Acral skin.
So acral skin, and then what's going on with this acral skin? Yeah, pitted keratolysis, and you see two things. You always have the rods as well as the micrococcus, and it's the micrococcus that stinks like Limburger left out in the sun. So
Toxic socks.
toxic sock syndrome is correct. If this were a scratch and sniff slide, you would know it's pitted keratolysis. And people with foul, smelly feet often have a little bit of pitted keratolysis they're not aware of, and a little clindamycin can make everyone in the house much happier. We're going to hold on to that one for the H&E to come.
The superficial perivascular pretty dense inflammation. I don't see anything in the horn. It looks basket leaf. It looks like the inflammation's almost palisading around that area. I can think of
Tell me about the lumen.
It's swollen. So you'd have to think about syphilis.
And you got a busy dermis. So there is interface, and there's sponge. So when you got weird combinations like spongiotic and interface, drug viral syphilis as your differential, in this case you actually have plasma cells, which are only present in 2/3. You've got the interstitial dermis, you've got the endothelial swelling, no lumen present, and you also have lymphs with too much cytoplasm. So even though the nuclei are black lymphocytes rather than gray vesicular histiocytes, there's a background of cytoplasm almost like a granuloma. So you put all those things together and you got syphilis. It is each year now it's breaking prior records. So if you are not seeing syphilis, it is seeing you. So keep a high index of suspicion. Okay.
So, in dermis, deep and superficial, it's got a lot of inflammation. Kind of like histiocytes.
Yeah, definitely
Looking
histocytic.
for maybe a bug or something.
And then you have these collections.
Yeah. Are those globi?
Those are globi. So this is leprosy. The American Journal of Dermatopathology this year had a patient presenting with classic myxedema, facial edema, bags under his eyes, hypothyroidism, except that on biopsy it was all leprosy, including the hypothyroidism was leprosy in the thyroid gland. And but you could see, they just hung out their dirty laundry, how you would go right down the garden path to myxedema, and then the biopsy was lepromatous leprosy. So leprosy and syphilis can affect multiple organs of the body. If you ever have anyone with generalized lymphadenopathy, think of syphilis. Nephrotic syndrome plus hepatitis, think syphilis. In fact, anything, think syphilis, right? It is the great imitator, and interestingly, the authors led off by, in many parts of the world, it's leprosy that's the great imitator. Right? So you have to think of that as well. So we've had them come in as solitary epidermoid cyst, coming in from a general surgeon, and it's lepromatous leprosy, so you will definitely see it. So, as you said, histiocytes, lepromatous leprosy, only in the diffuse lepromatous leprosy, L. lepromatosis form, is it sheets with grenzone. Others are perivascular and perifollicular aggregates. It loves to follow the erector pili as well as nerves, neurovascular bundle, and then the key is just the sea of histiocytes and recognizing the globi. This is a case just to show you the acid-fast stain, and you can see the organisms there within the globi. Acid-fast stains do fade over time. They also are not as sensitive as you might like. Auramine rhodamine is way more sensitive, and is how much of the world looks for leprosy. The Phyte and Kenyan stains is kind of an American-European thing. In India they do auramine rhodamine in many labs. Okay, this is just to give you how subtle it can be. This is also leprosy, and there you have anything horizontal to the surface following neurovascular bundle, parallel to the surface. You want to think of it, and in this case, the globi look almost like little lipocytes there, and you need the stain. The fact that there's something pink in the middle of it is your clue that it's, really is globi, not filler, not fat, not anything else.
So it looks like we have a lot of infiltrate with the busy dermis. The lymphocytes do look a little angular and atypical, but syphilis comes to mind.
Yeah, so it's a lymph in every hole pattern, right? There's interface with a lymph in every hole, so that's MF, 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 MF. Pityriasis lichenoides, early BLK. Syphilis can also do that. In this case, very focally, there were neutrophils in the horn, which is a clue to syphilis. Interstitial busy, interface with elongation of redi, although you can also have effacement of the redi. In this case, lumens preserved, but you do have a combination of spongiotic and interface with the busy dermis. No plasma cells that are jumping out at me, but you can't afford to wait for plasma cells unless it's okay for a third of your patients to go on to TABIs. So. Oh, there's a lot of syphilis in this class, which is good because we were missing a lot of our syphilis cases. This is by stain. The fact that it's a blue background is a clue that we're looking for acid-fast bacteria here. Remember, your mast cells are going to stain, so they're a nice internal control. If it's a properly done acid-fast stain for leprosy, hair should be positive. So hair shaft should be positive, and mast cells should be positive. So you typically have some internal control to tell you if it's working. In this case, you just have a little bit of lymphoid infiltrate down around the neurovascular bundle, so that would be actually pretty good for indeterminate leprosy. That's often all you see, just a little bit of onion skinning around the vessels, and then they over time can evolve towards either a lepromatous or tuberculoid pole.
A little.
Unhappy skin.
Yeah, it looks like a pole. I was thinking maybe. Looking at the top, I was thinking about bolus and Bitago, but it's pretty inflamed.
Yeah, and it's kind of inflamed all the way through. And it gets worse as you get deeper with vascular necrosis. And the biopsy doesn't go down to the level of the fascia, but the infection sure did. So, yeah, necrotizing fasciitis is usually a group A beta hemolytic strep, although it can be synergistic with different bacteria, but usually it's a pure streptococcal infection, as is cellulitis, as is erysipelas. So it's sort of cellulitis gone bad into the fascia. Often toxic patient, either pain out of proportion to clinical features or just the opposite, anesthesia at the point where they look horrible, and high incidence of morbidity and mortality, often with amputations. So you want to catch it early. If you do a gram stain, if you have tons of organisms in the subQ. So this is a gram stain from neck fash. This piece goes appropriately deeper, although you still have mainly sub-Q there. But what you'd expect in addition to the neutrophils is very tiny little cocci. So they're much smaller than staph, and they don't have the same tendency to aggregate into large clusters. If anything, you'll get very small linear rows, since strep tends to do linear arrays rather than clustering. So smaller cocci. Anaerobic strep and strep pyogenes are much smaller, about half the size of Staphylococcus, and form chains, not clusters.
So we have ventral face with lymph in every hole and a busy dermis. And plasma cells,
Yeah.
all suggestive of syphilis.
Yeah. So everything this morning is syphilis, and everything in your career may be syphilis. So it's important just to see the spectrum, right? So it's always clusters of findings. So congenital syphilis, you may have snuffles, you may have periostitis, which presents with porose pseudoparalysis, so fencer pose, one arm up, one arm straight down with the kid, and then odd combinations of pneumonitis, hepatitis, renal disease. My grandmother was a physician who had to leave med school because of World War I and became a frontline medic, and ended up, one of her jobs right after the war was whole wards of children with congenital syphilis, because the men came home with syphilis and then there was a baby boom. And she was injecting the arsenicals into the fontanelle. And years later, in New York as a physician, she was asked to consult on a child with refractory pneumonitis and hepatitis, and she walked in and the kid's in the fencer pose, and she said it was immediate back to that ward of children. So recognizing, go back right after this and read through Andrews, all the features of congenital syphilis, because one of these days you're going to be the person who walks onto that ward and sees the kid in the fencer pose and makes the diagnosis. So, it is definitely out there and underdiagnosed, and we're typically the ones to make the diagnosis. So.
There's a superficial perivascular infiltrate, and then I think the horn.
Yeah, a little hyperkeratosis. You want to look in that horn, and they're subtle, but you can see them. They're vertically oriented. They're not hollow like hyphae or pseudo-hyphae. They're vertically oriented the way Candida would be, but they're distinct gray vertical lines that you see in the erythrasma.
Okay, went down April, scan again. And it looks like pitted keratolysis.
And in this case, again, you see the vertically oriented rods, and the micrococci. That is indeed pitted keratolysis. Leprosy. Good. It is actually something that you suspect from scan. The other thing you would think of with this would be leishmaniasis. Leishmaniasis is more likely than leprosy to have plasma cells. That's one of the clues. And then, of course, the organisms look different. They're both within histiocytes, but globi, where it's usually right in the center that you get the aggregate of organisms, versus leash, which distinctly likes the periphery of the vacuole. So that's one of the clues.
How common would it be to have leash without PEH with pus? Like there's no real pseudo, there's no hyperplasia.
It depends on the stage of the leishmaniasis, right? So that's in a heaped up verrucous lesion that you're going to have PEH. Pseudoepitheliomatous hyperplasia. Leishmaniasis goes through clinical phases, and so in each of those phases you get a different histology. But the sheets of histiocytes, the affinity for both vessels and rector pili are all clues. So today, you're probably safe saying that for anything, right? If this came through the lab, we'd probably be thinking spongiotic dermatitis. There's a little bit of papillodermal fibrosis. There's no endothelial swelling. Minimal busy interstitial. The majority of cases of syphilis that come into the lab are undiagnosed. It's not suspected. It's not in the differential. The differential is drug eruption versus viral. And when you see combinations of inflammatory patterns, you think of drug and viral as well as syphilis. So you have to keep a high index of suspicion. This one you just hope you would have thought of it and done the spirochete stain. The immunostains are only positive in 70%. So again, you've got a stain that's not 100%, a condition that mimics many others, and so it's problematic and potentially a catastrophe waiting to happen.
So I think this is some sort of bacterial infection. It almost looks like sausages.
It does. So at scan, you might also think of something like tumid lupus, right? And look for mucin in that you've got superficial and deep. You don't really have interface change, but you have superficial and deep with involvement of equine coil somewhat. But there's also granuloma. In this case, the reason it's so highly inflammatory is this is reversal reaction. So in reversal reaction, the lymphocytes often overshadow the histiocytes. And one of the clues in this case is they're really beating on the nerve, right? So you can see the nerve pushed apart with all the lymphocytes in. Reversal reaction is when the biggest nerve damage occurs. Right? So the patient is walking around with somewhat anesthetic patches. You start them on therapy, and that's when they develop crippling disease. Right? So the art of treating leprosy is treating the reactional states. Reactional states, ENL occurs often during pregnancy. So, a young pregnant woman from Southeast Asia, Latin America. I mean, there are many places she could be from. Louisiana, who has patches in acral sites that show leukocytoclastic vasculitis. You have to think of erythema nodosum leprosum. The clue is the LCV is all around neurovascular bundle, including D, right? So you might be thinking of an ANCA type, of a big 5 type of vasculitis. Hopefully you'll see onion skinning of nerves and vessels as a clue that there was something chronic there before. Reversal reactions tend to occur during treatment. So you start therapy and then things go sour with pain, swelling, rapid nerve destruction, and early treatment with prednisone for reversal reaction, and then for others, clofazimine does have a role also, especially in ENL, as does thalidomide.
So punch biopsies, some kind of vertical columns of maybe the lymph, maybe these two sites. Down there lower looks more like kind of sausage.
Yeah, so you've got, first off, you have necrosis here, caseous necrosis, and you have lymphs, and they're all over the place, and this is a biopsy of a PPD reaction that's positive. And the reason to show it is it's all the sorts of things you can see in id reactions in tuberculosis. So we will see not only lupus vulgaris, which you may well see at some point in your practice, but you will see tuberculids. You'll see erythema induratum. You'll see papillonecrotic tuberculid that look kind of like pleva. One of the clues is you sometimes have caseous necrosis. Another clue sometimes is patient's origin from an endemic area. Usually we start with quant gold because the PPD you can get extreme necrosis. But if they are incapable of mounting a PPD reaction, then you know it's not an id reaction, because if you can't mount a PPD, you can't mount an id reaction, right? An id reaction is basically a generalized PPD reaction to the antigen. If you do PCR, you can identify organism, but there's no viable organism that you're going to be able to culture. Silver stain. Yep. And so, because immunostains are only positive in 70% of cases of syphilis, you need to be able to read the immunostain. So first off, where are you going to look at it? So let's look at this part. All of this stuff that is black and granular is melanin. Right, so you're going to have a lot of background melanin. It's black, it's granular, it can be in dendrites. Where you want to look for your syphilis organism is where you start getting either the acanthosis or the effacement. And then it's in the lower third of the epithelium. And you gotta hunt. They're not always there in large number. Let's look at the edge here and see if we can make them out. And they're going to be not granular and black, but linear and gray when you see them. It's like this slide has been looked at so many times, they've been burnt out a little bit. Let's see if we can find a nice focus in here, but it's right down towards the basal layer. They're vertically oriented, linear and gray. In fact, you can see that they look like spirochetes, right? They're spiral, and you can make that out. Okay, well, we're not going to find them to save our lives in this particular case. But, think of syphilis, it knows no economic boundaries, it knows no social boundaries. And the name of our specialty in European countries is still dermatology and syphilology, right? Because that is often what we do. So see that they're black lymphocytes, but you have a background of gray cytoplasm. That's a clue. Interface. In this case, you don't really have the long, slender, sexy reedy. You've got a neutrophilic infiltrate, almost like a little vasculitis. But again, you've got weird mixes. Neutrophilic infiltrate around vessel plus interface. Granulomatous plus interface. Odd combinations, think drug viral syphilis. And the most common change that helps you is that background busy dermis. That's present in almost every case of syphilis. So interstitial busy plus a combination of patterns. Think of syphilis. Endothelial swelling is the second most common feature. Elongation of reedy ridges is at about 80% of cases. And then, this is kind of the typical elongation of reedy. Now, this is also a little bit of a bleak cut that exaggerates it. But most interfate processes will efface reedy pattern. Syphilis elongates reedy pattern in 80%, but only 80%.
Seen epidermis nicks or deep. The vessels look really unhappy. There's newts everywhere, calcification.
And so with newts everywhere, there are a number of possibilities.
Really bad eczema. Could be neck rash, maybe.
Exactly. Could just be an abscess or cellulitis. And so you're going to look for organisms. In this case, they're not jumping out at you on H&E. You can get a gram stain. Culture is more sensitive than gram stain. And this was staphylococcal infection. Cellulitis is more likely strep than staph. Same with erysipelas. It's only when associated with abscess that the likelihood of MRSA goes up. Okay, be honest, how many of you would have jumped right to syphilis on this slide? That's what it was. So I don't see interstitial busy. I see a perivascular lymphoid infiltrate that could be just about anything, right? And this one was syphilis. So again, high index of suspicion. In this case, thank goodness the clinician had raised the possibility. And so even though there was very little non-specific, the IHC was done and was positive in this case. So, just to see the spectrum of disease. This is also syphilis. In this case, there's a little bit of sponge, barely a little bit of interface. You do have plasma cells. You don't have prominent lumen to the vessel, so you have endothelial swelling. You have the interstitial busy. You've got excess cytoplasm to the lymphs. So, that one, you had multiple features as a clue. Always nice when you have more features, but that's often not the case. This is another area of necrosis, and it's just to show you what staph colonies look like as opposed to strep. When you have botryomycosis, staph colonies, when they're small, they're round to oval. As they get bigger, they get irregular shapes, often with wings, arms, or antennae on them, which is one of the clues at scan to botryO rather than an actinomycetoma. Actinomycetoma grains stay round to oval. Staph grains, as they get larger, grow these little appendages. And then if you look closer, you can see their metacocci. Let's see what else we want to do here. So, again, lakes and lakes of pus. Very large staphylococcal colonies. And again, you can see this one. It's not entirely round. You can see the irregular outline where it's starting to send out little appendages, which is a clue to staph, again, at scan. Okay. Whose turn is it?
So, looks like vessels are not very happy.
Unhappy vessels. Why are the happy vessels unhappy? Is it neutrophils? Is it lymphocytes? Or is it a distinct absence of any inflammatory cell whatsoever?
So that last one that you said?
That last one that I said, a distinct absence of any inflammatory cells whatsoever, and instead, what's there?
Based on the chapter, I'm thinking of like
See how these are rods?
I see the blue haze there.
Yeah,
So is it
exactly.
echinacea?
So there's a blue haze, and in this case, you can really make out that they're rods. They're often blue haze because there's so many of them that some are alive and some are dead, and it just turns into this blue haze around the vessel. But the key to ecthyma gangrenosum is dead vessel, not an inflammatory cell anywhere, blue haze around the vessel, and if you look on higher power, you can often make out that they're rods. Clinical diagnosis: patient has Pseudomonas sepsis, will not survive without appropriate therapy, and diagnosis is often made clinically, usually intertriginous, highly vascular area with punched out undermined ulcer, and then either on swab Pseudomonas or biopsy Pseudomonas.
Syphilis maybe.
So this week, hopefully you would think of it other times as well. So you don't have much dermis, but you can see it's a little busy, and there's interface. And that's about what you had. Maybe you can make out that there's no lumen to the vessel here. But again, high index of suspicion. We saw enough of it in New York. New York is a very syphilitic place that the fellows would nail even tough cases at scan by the end of the year, because you start to pick up on the weird combinations of patterns in that subtle interface. Plus anyone from New Jersey. So
this one could also be syphilis, just at scan.
it could. You're probably a little more acral site given the corneum. interface change. Yeah, I see lumen to vessel, but there is some busy interstitial, and that was an acral lesion, palm and sole type lesion of syphilis. Doesn't have to do palms and soles. It's not in the contract, but it often does palms and soles, and that's a helpful clue if you see it.
Acral skin.
So superficial shave, but you do see neutrophils in the horn. And you see newts in the horn together with an interface process that's pretty much a lymph in every hole. Newts in the horn plus lymph in every hole interface, acral surface can help you think of syphilis. One more of those. Interface, superficial and deep, lymphs in the eccrine coil, lupus, lymphoma, lichen striatus, Louise being syphilis. Right, so superficial and deep with interface. At scan, you might be snookered into thinking lupus. The busy interstitial is not particularly a lupus feature and is a syphilis feature and may help you. The relative absence of lumen, struggling to say is it lymphoid or is it granulomatous. Those are all features to help you for syphilis.
I feel like you found the long lost syphilis box.
I think what may have happened is people put it back in bacterial box, which is why our syphilis box was empty. But we had like 5 boxes of syphilis,
Oh, wow.
so we haven't found them all. Yeah, New York, the citizens of New York rallied to and gave us lots of examples. New York is also a wonderful place. There's just lots of people there. So you see everything.
So a lot of inflammation in the upper dermis.
Neutrophils,
Neutrophils.
papillodermal edema. So what kind of things are in your differential?
Papillary dermal edema, I think of PMLE.
And is PMLE usually neutrophils or lymphs?
Lymphs.
So papillodermal edema with neutrophils.
So sweets.
And this actually was early sweets. So not everything with neutrophils is infectious. Okay. So sweet syndrome. The other thing, especially if there's a layered corneum, is bullisinia.
That looks granulomatous.
Yep, granuloma, edema. There was a draining sinus tract here. You can see all the scar, and it's right sort of just superior to the clavicle.
Where a lymph node would be? Or
I'm sorry, what?
I think of that as like lymph nodes.
Yeah.
There. Okay.
So what would give you a draining lymph node?
Infection.
Like any particular?
TB, like tuberculosis.
Yeah, so this is scrofula. Several of you have seen we see Anise Cooper, who looks just like scrofula, but she had a staphylococcal empyema that drained to the outside. But, your neck, clavicular area with a draining sinus tract, think tuberculosis. Increasingly in children in the U.S., it's atypical mycobacteria, so M. kansasii and others. Suppurative lymphadenitis in kids, head and neck. So, you think of look for mycobacteria, though, either TB or atypical mycobacteria, when you have suppurative lymphadenitis of the head and neck area. necrosis, neutrophils.
Is it vaccine gangrenosis?
So, too many inflammatory cells for an ecthymic gangrenosum, but what are these structures?
Is it global?
Yeah, so globi. So this, with all the neutrophils, is ENL, erythema nodosum leprosum. So, young pregnant woman comes in, has, in this case, looks almost suppurative, right, around the follicle, but there's a background of globi. Remember, in addition to neurovascular bundle, leprosy loves erector pili, loves the follicle in general. Okay, let's see what else. Just make sure we've hit some good things here. So, a little bit of spongiosis. I'm not sure I'm seeing interface, but I'm definitely seeing a little bit of busy interstitial. There's some neutrophils as well as limbs. There are newts in the horn. And it was tinea in this case. But it's good that you thought of syphilis, because it's the day you don't that you will miss it. Says someone who has missed it, right? The experience, is just a lifetime of catastrophes and misses that you've learned from, right? And so you don't, hopefully you can pass on the experience so someone else makes the diagnosis, doesn't miss the diagnosis.
That's syphilis again.
And you've got interface, superficial and deep. Now, what if it came in as rule out lupus?
Well, it's ruled out now.
Well, only if you got the spirochete stain, because there's mucin here. You have interface dermatitis. It's junctional and perifollicular. It's superficial and deep. There's some lymphs around the eccrine coil. There's mucin in the dermis.
Lupus can have mucin, right? Or not lupus, sorry.
Syphilis can
have mucin.
have
as well.
mucin, and this was syphilis. There have been about 20 posters in the last couple of years at the DermPath meeting of presentations suggesting connective tissue disease, biopsy redness lupus, ultimate diagnosis syphilis. So it can mimic lupus paniculitis, it can mimic neonatal lupus. There have been several reports of that, so you want to
It
be
doesn't
careful.
look like any of these cuts, like the basement membrane is thick like you see in lupus. Is that true, or can it syphilis do that
But
as well?
early, that's a late stage in discoid, right? So
Gotcha.
early, you're not going to see that
Okay.
in discoid LE. Okay, I think we've covered the main things we want to cover there, so let's take our last few minutes and do potpourri. You guys can refile those after and do some potpourri cases.
Touch biopsy, not spacious, nice face, kind of that acantholytic dyskeratotic, frond-like flares.
Yep. So what are you thinking?
Solitary, like a warty.
Yeah. Warty dyskeratoma. So you've got frons, villi, acantholytic dyskeratosis, solitary crateriform, or expanded follicle-like lesion. Warty dyskeratoma. Well done.
trichomona?
So kind of hangs off the epidermis like a trichomona, palisades like a trichomona, but there's no thick base membrane zone. Instead, they're papillary mesenchymal bodies and mucin. It anastomoses, so they're pink strands with blue buds, and it's the start of a pincus tumor. You know, superficial, early start of a pincus. Yeah. So that's spiroadenoma, that's cylindroma. They're often combined. It's variants of the same tumor. The spiroadenoma is just individual nodules rather than jigsaw puzzle, and has the lymphocytes, so it's the one that's tender. Let's see what we've got here. Tissue here, there we go.
Looks acidic. It's mostly dermal, but there's a true junctional component. It looks like it's maturing. I know it's heavily pigmented in areas, and some of these cells look really pleomorphic.
What do you think of that pattern?
I am worried about parallel peaks at the bottom there.
You got a little parallel feet pattern at the base.
Yeah.
And this is metastatic melanoma. This is epidermotropic nevoid met. So clues at scan: parallel theque at the base. You know, it looks like it matures, but it's parallel theque at the base. There is confluence at the junction. It's not knock your socks off confluence, but it's there. The other thing is you go higher power, and a number of these cells are rhabdoid. So those are, you know, all clues to epidermotropic metastasis. They can be very, very nevoid.
Looks like you've got a little bit of a split there.
How happy is your basal layer?
Not happy. Just trying to figure out if there's like, if the basal layer is like left there, if it's super, or if it's.
Well, they're dead reds.
Right. So I guess I'm thinking like a lichenoid.
So it's a lichenoid process. And so give me a differential.
So got lichen planus like drug, graft versus host, regression of the melanoma, BLK,
In acrocyte sacral lupus. So all of those, and this one was graft versus host, lichenoid GVH. You know, you need clinical pathologic correlation, but that's why you learn the differentials, because it could be anything in that differential.
So we have some dense infiltrated around the periapexal and perivascular structures, I guess lupus or syphilis.
So lupus and syphilis are reasonable thoughts. Syphilis is, if you ever say sarcoidosis or syphilis in a differential, I will, you know, you're never wrong to include those. How about this pattern? Granuloma between the collagen bundles. Focal, patchy.
Like
Patch here, patch there.
I'm not really sure.
Interstitial granulomatous.
Or IGTA.
And
Oh,
GA
okay.
can be very inflammatory, where the lymphs hit your eye before the subtle interstitial granulomas do.
Looks lichenoid.
So lichenoid acral
Maybe
skin.
hypertrophic lupus.
That's exactly what this is hypertrophic lupus. Well done. Someone passed that easy button over. So you're on acral skin, hypertrophic lichenoid. Process could be hypertrophic LE or hypertrophic LP. How are you going to tell them apart?
You have to do a DIF.
You do a DIF, and hypertrophic lichenoid lupus will always be strongly positive.
Have a small papule.
Well, what kind of skin are we probably?
Probably acral skin.
Yeah, probably not volar, but maybe like dorsum, acral. And then you have this.
Papillary structures.
So some have papillary structures, some don't.
Papillary adenoma.
I'm sorry, I think I heard it.
Papillary adenoma.
Yeah, so papillary eccrine tubular apocrine adenoma, PETA. Sounds like pita bread. PEATAA, papillary eccrine tubular apocrine treatment. Or ethical treatment of animals. Exactly. Could be any of those.
So this is a verrucous lesion. There's acanthosis, there's epikeratosis.
What do you think about maturation of the epidermis?
I don't think it's maturing very well.
No,
There's
exactly.
very large cells at the top, so Bowens.
Yeah, so it's Bowens. And what did this Bowens arise in?
I think a wart.
See the dyskeratotic cells at the base and the little parakeratotic columns here at the edge, and there's probably one at the other side too.
A
right there.
keratosis.
So it's Bowens arising in poro. So Mabelli type and linear poro are the ones with the highest highest risk of squame.
Definitely have PEH, acanthosis.
What do you think about your epidermal maturation
that looks
here?
Bowenoid.
So that looks Bowenoid, and this looks
Invasive.
invasive squame. And then over to the far edge, you have coarse hypergranulosis, coarse basket weave. This is all HPV induced, right? So this is genitals, HPV induced Bowens and squamous cell carcinoma. Someone gives you a hair shaft, right? So first off, when you see the keratin filaments here, are they all parallel or are they making V's?
V's.
And that's a clue to pull out your polarizer and polarize it. Do we have our polarizing disc here? Let's see, where's the...
Right there, the Olympus thing, I think.
Is it over here? So those V-like keratin is the hint to pull out, and there you go.
Beautiful.
And so what does your patient have? Trichothiodystrophy. Right, so trichothiodystrophy, which is in there with xerodermal pigmentosum in terms of genoderms. And you see the tiger tail, and the tiger tail comes from those alternating V's of keratin filaments. And you can see them on H&E when you look at the hair, and that's your clue to polarize. Isn't that beautiful?
Yeah. Gorgeous.
Okay. And
Oh.
interstitial and neutral.
Yeah, so there are some neutrophils here, which is actually, I'll tell you, is a red herring. There probably was an associated folliculitis at a plane of section there. But you have all these vessels, and you have cells like that all through.
Multinuclear.
Well done. Multinucleate cell angiohistiocytoma. Pass that easy button over. You get to choose your language.
That was easy. 100%.
So we had French and English there. So multinucleate cell angiohistiocytoma, and that's it. With that, we're done.
Thank you.